Hey there everybody, this will be the last video for the material for section 2. I'm going to redo a couple of slides at the end of, from the end of the lecture today. It was getting to be a little late in the 4-hour time span, and I want to make sure that I got this information across correctly. So this will be at least the most accurate if I did not say it correctly last time. But we're going to go over carbon dioxide transport and then hit the rest of the material in the respiratory physiology section. So I mentioned that carbon dioxide gets carried in the blood in 3 main forms. A small amount of it will be dissolved within the plasma as just regular old CO2. You'll also have some that's going to be attached onto the actual hemoglobin molecules. This is going to be that carbamino hemoglobin. So a decent amount can be attached onto there, and that's actual a protein, kind of a weak protein hydrogen bond that occurs between the CO2 and the amino acids on the hemoglobin molecule. And then finally, we saw that the largest proportion, about 70% of that carbon dioxide, is going to be switched over into the bicarbonate form, and that accounts for the majority of transport. And again, we mentioned that the process by which this occurs is that you're going to see that as the CO2 gets picked up from the tissue, this transports pretty easily over into the actual red blood cell. So you have carbon dioxide and water reacting with carbonic anhydrase to form the carbonic acid. Is then going to break down into bicarbonate plus a hydrogen ion, in which case that can then be shuttled out, and we'll talk about that chloride shift in just a minute. This is going to be the main way that we convert that CO2 into a more kind of accessible form, a form in which we can use it to help with the buffering system within the plasma. So we mentioned once that bicarbonate ion is going to be formed within the red blood cell, so you can kind of see that here. Once it goes from the carbonic acid over and dissociates into bicarbonate and the hydrogen ion, you can see that a lot of these hydrogen ions will combine with the hemoglobin. It can be carried there pretty easily. And then you'll find that the bicarbonate will be shuttled out of the cell, and chloride is going to be transported in. So it's kind of this co-transporter where chloride flows in, bicarbonate goes out. You have basically no change in charge because your one negative charge molecule is exiting while the chloride is coming in, which is also negatively charged. So again, this is called the chloride shift that happens here. And remember, this is happening at the actual tissue site, not in the lungs yet. So that Bohr effect is going to be important here because that bonding of the hydrogen ions to hemoglobin actually lowers that affinity for the O2 to hemoglobin. That helps with the unloading. So that was that process where we said having a more acidic medium, having more hydrogen ions around is going to allow for that oxyhemoglobin dissociation curve to shift over to the right and allow for better offloading of the oxygen to the tissues. And again, we know that the tissues are going to be a little bit more on the acidotic side because they are going through oxidative phosphorylation. They're producing that CO2, which ultimately kind of acidifies things. And so you'll find that the hydrogen ions also are going to help the blood carry more carbon dioxide molecules as well. And then basically this Bohr effect kind of describes that effect for pH on that affinity for hemoglobin to oxygen. We kind of talked about this before, but just to kind of reiterate this point here. So looking at the reverse of the chloride shift, so once you get the red blood cells traveling up into the pulmonary capillaries, this is where you're going to find that the increased concentration of oxygen, the increased partial pressure of oxygen, favors the production of oxyhemoglobin, or favors that binding of oxygen to hemoglobin to form that kind of stable molecule there. So basically this having the oxygen come onto the hemoglobin helps to have that hydrogen ion dissociate from the hemoglobin, and it's going to recombine with bicarbonate to form that carbonic acid. Okay, basically you're going to have as the bicarbonate ions enter into the cell, you're going to have chloride ions diffuse out of the red blood cell, right? So that's kind of the reverse chloride shift happening there. We're trying to get that bicarbonate back into the red blood cell so it can be converted back over into CO2 and water. So at the alveoli site, when you said the red blood cells have the carbonic anhydrase, it's going to be able to convert the carbonic acid back into CO2 and water. So you see that kind of conversion there. And then that bicarbonate, we know, is going to be highly lipid soluble. The CO2 is highly lipid soluble. It's able to cross these membranes very easily, get out into the alveoli. We can then be expired into the air, essentially. Okay, so again, this reverse chloride shift happens at the pulmonary site, whereas the normal chloride shift is going to be happening back at the side of the tissues. In this picture here, you can kind of see where you're seeing that reverse chloride shift happen. Again, alveoli on this side, the capillary blood on this side, chloride is going to be flowing out, bicarbonate ions back in, and they can be converted back to that carbonic acid. When it combines with the hydrogen ion, carbonic anhydrase converts it to CO2 and water. You also notice that carbamino compounds, they will then dissociate into carbon dioxide in that just a simple plasma protein, and that can also be expelled into the alveoli as well. And then just the dissolved CO2 is going to be traveling. So again, all this is traveling along this concentration gradient. It's going from higher pressure to lower pressure out in the alveoli. Whereas in the when you're at the site in the lungs, you're going to have the O2 distributing over and form that oxyhemoglobin. So again, reverse chloride shift in the lungs, you're going to have bicarbonate coming in, chloride flowing out. Carbonic acid is going to then get formed back into CO2 and water. Travels, CO2 can then exit through alveoli. Okay, talking a little bit about the acid-base balance of the blood. So looking at the principles of the acid-base balance, essentially what we're trying to do here is that we can maintain the body's pH pretty consistently between that range of 7.35 to 7.45. The kind of two major places where this is going to be maintained at is going to be within the lungs. We've already kind of seen some of the acid-base balances that are put in place there, and also with the kidneys. Basically, since carbonic acid can be converted into a gas and then exhaled, this is going to be considered a volatile acid, and this gets regulated by breathing. So we said that when you have hyperventilation, you breathe off more CO2, which gets formed from that carbonic acid, and that can help you to become more alkalotic. Versus if you're hypoventilating, you are going to be holding on to more CO2, and thus you get more acidotic. We're going to find there's plenty of non-volatile acids that cannot be regulated through the respiratory tract. So for instance, if you were to have lactic acid buildup, or some of these fatty acids or ketones that can be built up, they can be buffered by bicarbonate, but since they cannot be regulated by breathing, they have to be regulated through the kidneys, which means we have to get rid of them somehow, that or metabolize them in some other place. But primarily, you can see that the kidneys will be another place where acid-base status is going to be hopefully maintained. A lot of that can be done through managing bicarbonate. So essentially, one of the things you'll see when you end up having an alkalosis, especially being done through the respiratory side, one of the things that the renal tubules can do is increase the excretion of bicarbonate. You can see bicarbonate coming over this side. Carbonic anhydrase also is going to live within the kidneys. It's one of those things where you can actually have bicarbonate being excreted through the kidneys if you're in an alkalotic state, or you can reabsorb more bicarbonate through a similar process back into the blood if you're more in an acidotic state. So we'll kind of go into more detail on that in just a minute. So the first thing we're going to look at will be acidosis. And again, this is going to be when the pH of the blood is going to fall below 7.35. This is primarily talking about the arterial blood pH. Obviously, the venous side is always going to have a little bit lower pH than the arterial side, just due to the balance of CO2 and consequent hydrogen ion concentration. But anyway, so we're looking at our arterial pH, and then we're going to be assessing for things that are causing acidosis. And it's important to determine whether it is a respiratory acidosis in nature or it's more metabolic in nature. It's a pretty easy way you can determine that right off the bat. And so that can be either by looking at your bicarbonate ion concentration, which you'd be able to measure on something like a basic metabolic panel, or you could be looking at the partial pressure of CO2 within the blood, which you would see like an arterial blood gas. Okay, and this, again, we'd be looking for elevated levels of CO2 in this case. Some reasons that you could have a respiratory acidosis would be something like hypoventilation, which would cause an increase in CO2. Again, we said that was hypercapnia. That would increase CO2. That increase in CO2 would end up increasing your hydrogen ion concentration, and you'd have a consequent pH decrease. We see this a lot with patients who overdose on like opioid medications, which can cause that basically kind of shutting down that respiratory drive from the brainstem, leading patients to basically not have that same trigger to elevated CO2 levels like a normal patient would, and that causes them to slow down their breathing. They start to build up CO2, and they get this respiratory acidosis, right? So again, it's all generated from the lungs themselves. On the flip side of that, you can look at a patient's bicarbonate level and determine whether or not they have a metabolic acidosis. And so this is usually either done by based on excessive production of acids. So think about like if you had a lactic acidosis, if the muscles were starting to generate a ton of lactic acid all at once, or if you had like say a loss of bicarbonate ions. Big reason for this could be like diarrhea. We know that the stomach is generally pretty acidic for the most part, but the small intestine, the colon, tend to be much more on the alkalotic side, and they do this by secreting secreting bicarb. And if you are having pretty extensive diarrhea and you're not able to reabsorb some of those ions very effectively, this can lead to some pretty significant losses of bicarb, leading to a metabolic acidosis. There's actually a really good mnemonic that you guys will learn. You guys will have this memorized, no problem, by the time the end of this year comes up, but it's called mud piles. And mud piles is a very common set of things that can cause metabolic acidosis. And so it stands for methanol, which is a type of windshield washer fluid, uremia. That could be a patient with like kidney dysfunction, can develop uremia that could lead to metabolic acidosis. There is diabetic ketoacidosis, which we see occasionally in some of our type 1 diabetic patients. There is paraldehyde, which is a really old school drug that we don't really see used anymore that used to cause metabolic acidosis, but we just really keep it around in the mnemonic nowadays, so it makes sense. Mud Isles is not really as good of a mnemonic. The I is going to stand for iron. Iron ingestions could actually cause an acidosis. You can end up... The L is going to stand for lactic acidosis. Having a buildup of lactate can cause your pH to drop. The E is going to stand for ethylene glycol, which is also radiator fluid. And then finally, S is for the salicylates, or things like aspirin, so if you had an aspirin overdose. So notice a lot of those things are kind of tox-based. So it's really, really important if you have those type of patients to assess them for their acid-base status. And again, we'd be looking at their basic metabolic panel to look at their bicarb level to see if that's low. And if that's low, that can give us an indication that, hey, there's probably some sort of metabolic acidosis going on, and we would work that patient up for one of those mud piles. Again, I'm not going to test on it, that mnemonic for this test, but just know that you're going to hear that again in your future classes. And then on the flip side of that, we can look at our alkalosis, which is going to be our arterial pH greater than 7.45. Again, you can be looking at your basic metabolic panel to determine if it's going to be a metabolic alkalosis. Metabolic alkalosis could be caused by inadequate production of acids, so maybe you were not producing enough lactic acid or things like CO2 or things like that. Sometimes you have overproduction of bicarbonate ions, or perhaps you were having too much reabsorption of bicarbonate ions in the kidneys. Sometimes you can have patients who actually end up taking too much baking soda, and that would actually end up leading to them to have elevated bicarbonate levels due to that. You can also have some loss of digestive acids from vomiting. So loss of those acids would also lead to pH to be elevated as well. Okay. The other side of that is going to be the respiratory alkalosis, which would be indicated by that partial pressure CO2 on the ABG, less than 40 millimeters of mercury. And that could be caused by hyperventilation. So patient is blowing off too much CO2 when the CO2 is low. Obviously, the hydrogen ion concentration decreases, and that pH is going to increase as a consequence of that. Again, by looking at the BMP, by looking at the ABG, we can kind of determine, okay, is this going to be more metabolic, or is this going to be more respiratory in nature? So just to summarize some of the information here, again, respiratory acidosis will be defined by this increased CO2 retention, oftentimes due to hypoventilation. That's going to result in that accumulation of carbonic acid. It's a fall in blood pH to below normal. Metabolic acidosis is typically due to production of non-volatile acids, usually the things you cannot blow off, essentially lactic acid, these ketone bodies, or if you have a loss of blood bicarbonate, such as diarrhea being one of the main causes. Again, blood pH is going to fall below normal levels. Respiratory alkalosis, that rise in blood pH usually due to a loss of CO2 and carbonic acid to hyperventilation, whereas the metabolic alkalosis is generally going to be due to loss of non-volatile acids, such as due to excessive vomiting or excessive accumulation of the bicarbonate base. And then finally, this kind of new concept would be this compensated acidosis or alkalosis. And so essentially, this is the body trying to maintain homeostasis. And so what can happen is, say, for instance, you have a respiratory acidosis. Let's say you have a state where you are holding on to too much CO2. You are getting more acidotic. Well, what can the body do to compensate for that? Okay, you will find that the body will compensate for the lungs, and the lungs will try to compensate for the body in either of these cases. So in the case where you have a respiratory acidosis, the body can do things like try to hold on to more bicarbonate ions. So perhaps it'll try to have increased retention of bicarbonate in the urine, and that way it tries to balance out that pH. Some cases you could have a respiratory alkalosis where you're breathing off a lot of CO2 and the body can respond by getting rid of excessive base. It can actually start to pee out bicarbonate through the urine. This is actually a thing that we have happen with aspirin overdoses. Aspirin actually will directly stimulate the respiratory drive and lead to hyperventilation. So patients will be breathing off a lot of CO2, so they end up developing a respiratory alkalosis, and then the kidneys try to respond to that by trying to get the pH back down to a normal level by excreting a lot of bicarb. Okay. So again, the body can only maintain this compensation for so long, and eventually it can tire out those mechanisms, in which case you're going to kind of go off the rails a little bit and go either too high in your pH or too low in your pH, depending on kind of what the situation is. Now, for instance, if you were to have, say, a metabolic acidosis, so you're generating too much of these acids within the body, what the lungs can do to respond to that, to compensate, could be to breathe off more CO2. So if you had an acidosis going on, your patient can start to increase their respiratory rate to try to blow some of that off. Sometimes you'll see that kind of labored breathing, that increased hyperventilation with some of those like diabetic ketoacidosis patients. They're trying to blow off as much CO2 as they can to compensate for all these non-volatile acids that are forming within the body. On the flip side of that, you could also have, a metabolic alkalosis, and the body may try to, the lungs may try to compensate by, say, slowing down your breathing and maybe holding on to more CO2 to try to keep the pH in a normal range. Okay, so either way, whatever you have to find out what the kind of the baseline problem is, figure out if there's any compensation going on from the opposite side. So if it's a respiratory issue, is the body trying to compensate, and then how can we fix the underlying problem in order to make sure the patient stays within the normal range without kind of exhausting these compensatory mechanisms. Okay, so we have our good friend, the Henderson-Hasselbalch equation, making his appearance again. And again, normally what you're going to see is that normal blood pH is maintained when you have that bicarbonate concentration maintained at a ratio to CO2 at roughly 20 to 1. So when you actually look at this, you can calculate this out. So you can see that the pH is equal to 6.1 plus the log of whatever your bicarbonate is divided by 0.03 times the partial pressure of CO2. That basically converts it so everything is right in the correct units. So for instance, if we were to look at the levels we were talking about before as kind of our cutoff points for acidosis or alkalosis, say for instance we were to take that 0.03 and we multiplied it by a normal PCO2 in the arterial blood, and we say that was 40, right? So 0.03 times 40, you guys can do this along with me, would equal about, 0.03 times 40 equals 1.2. Okay, so if 1.2 is going to be in the denominator here, as you can see, so 1.2 would be down here. And we said that our normal bicarb, we said was going to be 24. So if we did 24 divided by 1.2, what you're getting is a value of 20 for this. So we can take the log of that, which equals about 1.3. And so if you take 1.3 plus 6.1, what do you get? You end up getting 7.4. And we said 7.4 is roughly a normal pH for us. We said 7.35 to 7.45. So that kind of makes sense. You can plug that in with any range of values for your patient to determine kind of what their pH should be, based on if the value was not expressed on the ABG for whatever reason. But this relationship should be maintained at roughly a ratio of 20 to 1 essentially. We know that a respiratory acidosis or alkalosis is going to occur with any kind of abnormal CO2 concentration, whereas the metabolic acidosis or alkalosis typically occurs when you have abnormalities in the bicarbonate concentration. Okay, so I can look at a basic metabolic panel. I can look at that bicarbonate concentration and say, okay, we have something going on metabolically. If it's low, you have probably some sort of acidosis, or if it's high, I know that we have some sort of alkalosis. Conversely, I can look at an ABG, look at the CO2 and say, okay, we're holding on to too much CO2. There must be some sort of acidosis going on here, versus if we're blowing off too much, we had the opposite effect. So again, you'll get pretty good at this over time when you're evaluating these patients and evaluating these labs together to see kind of what the acid-base status for the patient in total kind of is. So remember that ventilation controls the respiratory component of the acid-base balance, so that hypoventilation is going to lead to that ventilation that is insufficient to blow off that enough CO2, so that's going to build up CO2. When that's high, carbonic acid is high, respiratory acidosis occurs. The flip side is going to be true as well. When hyperventilation happens, you're going to be losing CO2 faster than what you can actually produce metabolically. Less carbonic acid, less PCO2, more respiratory alkalosis is going to develop. pH is going to rise in that case. So I mentioned already that the ventilation can compensate for that metabolic component. So as a person develops a metabolic acidosis, either due to loss of bicarbonate ions or production of new acids, these non-volatile acids, the body responds by hyperventilating and blowing off CO2. The hydrogen ions will decrease and the pH should rise, hopefully back to a normal concentration. So you can kind of see that in the rest of the slide here. So if you had a metabolic acidosis, or bicarbonate levels are low, the respiratory compensation is to try to get the PCO2 low as well in order to raise that pH up. Okay? A person with metabolic alkalosis will tend to hypoventilate. They're going to have a slower respiration, which will build up CO2 and hydrogen ions, and thus the pH will lower. So if you're looking at this side, the alkalosis, notice the bicarbonate level is going to be high. Metabolic alkalosis is determined at that point, and then the body will compensate through the respiratory tract by trying to increase PCO2 levels, which should get you a little bit more acidotic and get you on the side where you are going to be in the normal pH range. Here's another good table showing you basically the effects of the lung function on the blood acid-base status, right? So looking at a condition that's normal, your normal pH should be, arterial pH should be between 7.35, 7.45. Normal PCO2 concentration, say around 39 to 41 millimeters of mercury. Ventilation should be totally normal, and there's no really cause for acidosis or alkalosis. There's no compensation going on here, okay? Now, if you were to have a respiratory acidosis, your pH would be low. You would have a high PCO2 issue right here because you're holding on to more CO2. The problem is generally going to be this hypoventilation that's happening here, and this is the cause of the acidosis, right? Because you're acidotic and your PCO2 is high, so that indicates you're not ventilating enough to blow off that CO2, so that would be the cause of the acidosis. Looking at a respiratory alkalosis, your pH would be high, PCO2 would be low because you're blowing that off. Generally, the patient would be hyperventilating at that point. And again, this would also be the cause of the alkalosis. So the patient is alkalotic, PCO2 is low. That means that is the cause of the alkalosis from the respiratory side. Looking at a metabolic acidosis, you would also have a low pH. Here you would notice that the PCO2 would end up being low as well. This is that compensatory mechanism where the patient's hyperventilating to try to breathe off some more of those volatile acids, and that is a compensation effect there. Okay, so the lungs are trying to compensate for the extra acids that the body's producing by blowing off CO2. Whereas on the metabolic alkalosis, pH is going to be high in this case. PCO2 would also be high because now you're hypoventilating, trying to hold on to CO2 to compensate for the extra bases by getting more acids in the blood. Okay, so again, this is the compensation as well. Again, there's only so much compensation the body can do from either end, whether it be on the kidney side, whether it be on the respiratory side. And once you overwhelm those compensatory mechanisms, that's when the patient can kind of have overwhelming acidosis or alkalosis. The patient gets very sick at that point. So moving on, we'll look at the effect of exercise and high altitude on respiratory function. So looking at ventilation during exercise, we know that when you exercise, you're producing deeper, you're having faster breathing, and this is in order to maintain the oxygen utilization and also the CO2 production that's happening here. So we'll have hyperpnea. Hyperpnea is going to be this increased depth of breathing. You're going to be having larger inspirations. It's called hyperpnea. And then you're going to have tachypnea, which is that increased rate of breathing. So again, if your normal breathing rate at rest is say 12 breaths per minute, maybe it goes up to say 20 breaths per minute. So it'd be tachypnea. So looking at some of the changes in respiratory function during exercise, we see that as far as ventilation goes, it should be increased. So we know that with the increased metabolic demands being placed by the body, we are going to have increased depth and rate of breathing, so hyperpnea and tachypnea happening there. And so for the most part, your body can keep up with those demands to some degree, especially with just kind of moderate exercise. Looking at the blood gases, you typically see no change here. So blood gas measurements during light to moderate exercise should not find any kind of real appreciable changes because our ventilation is increased, and that's going to help to meet that matched increase in muscle oxygen consumption and carbon dioxide production. Obviously, with like kind of strenuous exercise or things that are kind of long-term exercise, certainly you can start to see more anaerobic metabolism happen in the skeletal muscle that can lead to more acids being produced and some decreases in pH, but then your body is going to try to compensate for that metabolic acidosis by breathing off some of that extra CO2 or trying to hyperventilate, right? Looking at oxygen delivery to the muscles, we notice there should be some increase here, and that even though the total amount of oxygen content and the actual PO2 of oxygen within the blood do not really change at all, we know there's going to be an increased rate of blood flow to the exercising muscles. So more blood flow to those muscles, more oxygen ultimately going to be delivered there. And what we see with the muscles is they're going to have an increased oxygen extraction rate, mainly because as those muscles are working, they're producing more ATP, they're using up the oxygen there, the PO2 within the tissue is going to lower. And we know that when we get lower down on that oxyhemoglobin desaturation curve, they're going to have more and more of that oxygen dissociating from the hemoglobin and donating itself to the tissue. Okay. Also, due to the fact that you're getting more acidotic, you're going to be getting, you're going to have higher CO2 concentrations, which is going to lower the pH, higher temperature. All of that's going to be shifting that oxyhemoglobin saturation curve to the right, which is going to lead more oxygen to offload to the tissue. That means more is being delivered to the muscles for utilization. We can pick up all that extra CO2 and then take that up to the lungs for removal. Okay. And then looking at some of the blood gas measurements at different altitudes, you can see here at sea level, normal arterial PO2 somewhere around the 90 to 100 level here. The percent oxyhemoglobin saturation should be around 97%. And then if you're looking at the arterial PCO2, should be around 40 or so. Notice as we start to get higher and higher altitudes here, you're going to notice that the arterial PO2 is going to be dropping accordingly. You're going to have the total percent of oxyhemoglobin saturation actually going to be going down pretty consistently as well. And then the arterial PCO2 concentrations, again, because the pressure is going to be lower here, is also going to be going down additionally. So the way that the body is going to try to respond to this, so immediately this decreases in PO2 stimulates those carotid bodies to increase ventilation. So you're going to start to be breathing either deeper or more frequently. And the hyperventilation is also going to end up lowering PCO2, causing a respiratory alkalosis. Okay, this means that by causing that alkalosis, especially within on the pulmonary side, you're going to have that increased affinity for hemoglobin for oxygen, which means you're going to have that kind of leftward shift, the oxyhemoglobin desaturation curve. Okay, this means you're going to get better oxygen loading within the lungs, which means you're going to be able to utilize the oxygen there a little bit more efficiently. Okay, so it's kind of an immediate thing that you're going to end up seeing there. And again, you can kind of see this on this slide here where you have high altitude, low PO2. The first thing you see immediately is going to be those carotid bodies being affected. Hyperventilation occurs here where you have an increased proportion of fresh air getting to the alveoli. PCO2 decreases, you get a respiratory alkalosis and a higher affinity for hemoglobin to oxygen. So you have better loading, and then you can offload that oxygen out into the tissues. Over the course of days, when you stay in the high altitude setting, you're going to find you have an increase of a product called 2,3-DPG, or this diphosphoglyceric acid. Basically, this will end up being formed in the red blood cells as kind of a side reaction that favors the conversion from oxyhemoglobin to deoxyhemoglobin. Essentially, that 2,3-DPG will sit into the deoxyhemoglobin, kind of help to stabilize that conformation to a higher degree. What this does is actually help to decrease affinity for hemoglobin to oxygen, and will help to increase the unloading of oxygen out to the tissue. So now we have a compensatory mechanism to get better oxygen binding within the lungs. We're also going to have an increased ability to now offload oxygen at the tissues itself. Okay, so again, this would end up shifting the curve over to the right if you were to be looking at that when considering this 2,3-DPG. And then over the course of weeks, you're going to find that the kidneys are going to respond. Again, we said that the endocrine system is typically takes longer to respond in a lot of these cases, so this is a slower process. But the kidneys can increase secretion of erythropoietin. It's going to cause the bone marrow to now start to produce more red blood cells and then hemoglobin, and thus we get total increased amount of oxygen content being delivered throughout the blood and throughout the tissues. The more hemoglobin, more of it can bind up oxygen, more of it can be delivered ultimately. So again, just kind of showing the full picture here. Again, this is going to take, you have the immediate effects that occur mainly due to the effects of the carotid bodies. Over the days that occur after that, you're going to find that the increased amount of 2,3-DPG helps to allow for better oxygen unloading of the tissues. And then finally, the effects of the kidneys, releasing erythropoietin, help to increase the total amount of oxygen content present within the blood. All right, so that finishes it up for respiratory physiology. It's also going to be the last section for, or the last unit for section 2. So we'll have the review probably either Wednesday or Thursday, and then we'll have the test on Friday. So in the meantime, if you have any questions, please feel free to send them to me or come by my office. Just remember, everything goes from the blood and heart all the way down to the respiratory system. Again, any clarifications or anything you need me to make, please let me know, and I can try to either get those out to the rest of the class, or we can discuss them in detail. All right, thanks a lot, and I'll see you guys in class.